pre-lunch session 5, which was interrupted by the lunch break. And we had just one talk from the 5 talks which were supposed to be there. So continuing from there, I request our chairpersons, Dr. Rajesh Tiwari, Dr. U.P. Bhadani, Dr. Shekhar Chaudhary, Dr. Nagendra Prasad, Dr. Shivendra Sahai, to please come to the dais. Vandana Tiwari and Dr. Nishit Prakash to kindly come to the dais. G. Sitapati, we've heard him and he needs no introduction now. To please give his keynote address on transorbital approaches to orbital SOL.
And thanks once again. So the next few minutes I'll be running through transorbital surgical approaches to orbital space occupying lesions. Orbital neoplasms, based on their origin, they can be either primary, secondary or metastatic, or based on the tissue of origin, they can be osseous or cartilaginous, they can be vascular, nerve sheath related, and neuroepithelial or meningiomatous tumors, mesenchymal tumors, carcinoma, and cystic and inflammatory lesions. Of course, this classification is just the modification of the WHO standard classification we all use. I normally try to break it down to working classification. So surgical space of the orbit, as we all know, is the preseptal, subperiosteal, extracorneal, intracorneal, and the posterior subtenon space. Conventionally, the orbit was approached by extraorbital approaches, and they evolved from the very cumbersome transcranial approaches, and then the transantral approach and the transnasal approaches. And later on, with the advent of more and more focus on aesthetic and functional outcomes, they became transorbital approaches. The transorbital approaches include superior orbitotomy, which can be either through the brow or the eyelid crease, a lateral orbitotomy, which is through the Burr crease or the lateral subbrow approach, a medial Lynch or transcaruncular orbitotomy, and an inferior transconjunctival orbitotomy. Apart from that, in very select cases, there could be an external lower eyelid crease approach, and preseptal lesions are usually approached by the eyelid crease. And surgery for orbital neoplasms can be either an FNAC for tissue sampling or an incisional biopsy, and complete or excisional biopsy and surgical debulking, depending on the case. And exenteration is done and as a last measure and also as a palliative procedure, and that's the orbital equivalent of a wide local excision. And there are again different subtypes in exenteration. Anterior orbital lesions are usually removed by a preseptal approach, like this gentleman, this young boy here, who had a preseptal dermoid cyst that was removed by a subbrow incision that you can see that's well masked, and that's the pre and post-op. And sometimes lacrimal lesions overlying the lacrimal sac fossa can actually have an orbital origin, like this lady here, who had a solid mass overlying the lacrimal sac fossa. And always we have to have in mind the need for imaging in lacrimal, pre-lacrimal lesions, depending on the case. And whenever it does not follow the usual rule of discharging eye with matted lashes and positive sac test, then probably we are dealing with something else deeper and sinister. And that's what we found on imaging. We found that she had a lesion arising from the ethmoidal sinus to the anterior prelacrimal region, and it was also causing a secondary nasolacrimal duct obstruction. And this was approached by a modified Lynch orbitotomy, and you can see that the mass has been removed in toto, and you can see at the base of the incision, you can also see the lacrimal sac fossa there, and through a single incision, we removed the mass, but unfortunately the mass was inseparable from the lacrimal sac, and we had to do a DCR as well through the same setting, and the HPU was a fungal granuloma. Vascular neoplasms are another subset of tumors that's seen in an orbit clinic, and the commonest ones are the cavernous hemangioma. Then we have the arteriovenous malformations, the lymphovenous malformations, and solitary fibrous tumor or the hemangiopericytoma, and then the malignant counterpart, which is fortunately rare, called the angiosarcoma. So this is just a depiction of a lateral orbitotomy being done for removal of a vascular cavernous hemangioma. Intracorneal vascular space occupying lesions need not always follow the rule. They can also be intracorneal and extracorneal at the same time, like this young patient's CT scan here, showing a vascular neoplasm that is occupying both the intra and extracorneal spaces, and that was removed by a supromedial approach. You can see the incision that's masked just below the eyebrow on the supromedial aspect, and that's the pre and post-op pictures after removal. And this patient came with another vascular malformation, which was actually an orbital varix that was already treated medically but was not responding to treatment, and so he had to have surgical debulking, and he underwent cryodissection with amniotic membrane grafting, and that's the resected specimen in the central picture there, and the pre and post-op pictures as you can see. And lacrimal gland masses again form a very important aspect of surgical management. And this was a right lacrimal gland mass seen on CT scan. It's a large space occupying lesion that's occupying most of the extracorneal space, and that's being removed by a subbrow lateral orbitotomy. And the HP turned out to be a lacrimal gland lymphoma. And usually for lymphomas, we don't do extensive surgery, and we normally do a biopsy and we go on to manage them medically. Or by radiotherapy, but in this case it was only a solitary mass that was indolent and slow growing and didn't have the other characteristic features of lymphoma until we confirmed it on histopathology, which is why we did this. And that's the same patient with the isolated lacrimal gland lymphoma, pre and post-op. You can see the well masked lid crease, subbrow approach, showing resolution of his signs in the previous picture. And this was a 35-year-old male who had a progressive prominence of the right eye, and he had an infranasal dystopia of the right eye and secondary upper lid, secondary unilateral dry eye of the right side alone, with no systemic complaints. And again, his MRI showed a well-defined lacrimal gland mass that was removed by an eyelid crease approach, as seen here, and that's the postoperative picture with resolution of symptoms. And the HPE was a pleomorphic adenoma in this case. And sometimes lacrimal gland masses can also not follow the conventional rule because of certain other anatomical variations in the orbit. Like this lady had large lacrimal gland masses of both the orbits, and she already had a pre-existing craniosynostosis, which is why she did not have the conventional S-shaped ptosis and the other features, and rather she came with an early onset proptosis and also the disfiguring masses with the extreme lag of thalamus as well. So again, she had indolent, slow-growing, massive masses in both the orbits, and she underwent sequential lateral orbitotomy for removal of both the masses. And the HPE was quite surprising. It was an isolated Castleman's disease of the lacrimal gland, which is nothing but an angiofollicular lymphoid hyperplasia. All the pre-op workup for typical multicentric disease was negative because it was one of the subset of lymphoproliferative disorders. And in this case, because of possible coexisting IgG4 hypergammaglobulinemia, we also did her serum IgG4 levels, and that were normal. And because she had an associated craniosynostosis, she required surgery for sight-threatening complications. And again, to mention, the lesion was basically refractory to anti-inflammatory medication, including steroids, which is why we chose surgery. And floor of the orbit, on the other hand, can be approached transconjunctively, like in this 24-year-old male who had painless swelling below the left eye, 6 months duration, insidious onset, slowly progressive, with a palpable mass in the anterior inferior orbit. And that's the mass shown in the CT scan. And that's being removed by transconjunctival orbitotomy, and that's the mass removed in toto. That's the pre and post-op. And coming to nerve sheath tumors, we have optic nerve sheath tumors which can present as an apical intracorneal space occupying lesion, like this MRI of a very elderly gentleman who presented with progressive proptosis, loss of vision in the left eye with a dull boring retrobulbar pain, and he presented 6 years after the onset of symptoms. And you can see the very subtle features in the left eye. He just has a very slight dystopia, and this was removed by lateral orbitotomy. And it was found to be an optic nerve sheath tumor, which is quite uncommon for this age, and it was a kind of a schwannoma. Schwannoma is usually in the, it was a kind of a neurilemoma, which was different from a schwannoma in the orbit, which is more common peripheral nerve sheath tumor. And this is just a benign neural tumor, which is potentially sight-threatening and is thought to arise from the perineural sympathetic nerve plexus, which is the most probable source of Schwann cells around the optic nerve. So This was the post-op picture of the same gentleman after lateral orbitotomy. And this was another nerve sheath tumor in a 32-year-old female who presented with the progressive left proptosis of 2 years duration with associated dull periorbital pain and diplopia and upgaze. And this was the mass in the posterior part of the orbit. And it was also seen to be attached to the roof of the orbit. And this was removed by subbrow orbitotomy. And the histopathology was a classical hemangiomatous meningioma, an angiomatous variant of meningioma, which is a low-grade tumor with abundant blood vessels. And a complete excision is a treatment of choice in this small subset of meningiomas, and that was done. It was quite rewarding in this patient. That's the post-op picture. Plexiform neurofibromas also can be quite a challenge to the orbital surgeon, like this lady with classical type 1 neurofibromatosis with all the deformities of ptosis, proptosis, and gross lower eyelid ectropion. And that's the orbital pictures showing also a dysplastic sphenoid. On the right side, you can see that there is a pre-existing deficiency of the greater wing of the sphenoid shown on the lateral wall. And that's the diffuse ill-defined mass occupying most of the orbital cavity. And those are the close-up pictures, clinical, and also the axial views to show the defect in the sphenoid. And that's the defect there. And she had a surgical debulking. Basically, she wanted cosmetic improvement because she thought her face was getting more and more disfigured. So I did a combination of lateral orbitotomy, surgical debulking of the tumor, combined with a ptosis correction in the same setting and a lower lid ectropion correction by horizontal lid shortening. And that's the immediate post-op result. And she seemed to be doing quite well. And the orbital surgeon also has to keep in mind metastatic disease. Like this elderly lady, she had been neglecting a breast lump for many years, and she presented with diffuse swelling in the superior orbit on the left side. And after workup, we suspected a metastatic disease, and she, for cosmetic reasons, it was very surprising, she was not bothered about the breast lesion that was possibly going to kill her, but instead she wanted treatment for the lump from the eye to be removed. And that was removed, and obviously, as we had thought, it had just confirmed a metastatic deposit, which you can see in the left superior orbit, and that's the resected specimen. And she was subsequently referred to oncology for palliative treatment because usually a metastasis is associated with poor outcome. And extracorneal space occupying lesions, especially involving the floor, again, as I told, can be approached transconjunctively, like this lady here who had an ill-defined mass in the inferonasal orbit. And that was again removed transconjunctively. The transconjunctival approach offers excellent exposure of the inferior extracorneal space of the floor of the orbit. It's also cosmetically rewarding. And the HP in this case was a parasitic granuloma. And that's the lady's pre and post-op after right inferior orbitotomy, transconjunctival. The supromedial orbital SOLs again can present a challenge to the orbit, to the orbital surgeon. And one word about supromedial lesions is that because of the space and the anatomical configuration, the proptosis and the dystopia, they don't show out until very late in the disease. So this was a young gentleman who had an insidious onset swelling around the left eye and also epiphora of about 1 year duration, but he had no clinical evidence of dacryocystitis, but he had a secondary left nasolacrimal duct obstruction. He had duct obstruction in the absence of dacryocystitis. And this was after imaging was removed by a Lynch medial orbitotomy. And unfortunately, because the lacrimal outflow was also obstructed, he had a DCR with lacrimal intubation through the same setting. And the Lynch approach has to be modified for 2 reasons, especially when we are dealing with the lacrimal outflow structures to prevent damage to them and also to prevent damage to the trochlea, which can result in an acquired Brown syndrome in many of these patients if not handled properly. So that's the gentleman post-Lynch medial orbitotomy, and you can also see the lacrimal intubation tube that's placed there, and that's the Lynch incision, and that is usually slightly different. It's supromedial compared to the conventional DCR incision, and it offers excellent reach to both the subperiosteal and the extracorneal spaces. The Berkery's lateral orbitotomy is another commonly performed aesthetic orbital surgical procedure. And this is just one such example. This was a 24-year-old female with type 2 neurofibromatosis with left orbital space occupying lesion. She was referred to me by a neurosurgery colleague. You can see that she has a nice globular swelling in the left orbit. and she also has bilateral CP angle tumors, as you can see there. They're probable acoustic neuromas. And for the time being, because her visual symptoms were predominant, the neurosurgeon wanted me to operate on this first, and he had meanwhile put in a shunt to take care of the raised ICT and then handed over the patient to me. And she had a bilateral CP angle SOL causing papilledema, and this was risking the left optic nerve even more because the optic nerve had compression both from the orbital side as well as the intracranial side. And this was removed by Berkeley's lateral orbitotomy, which is through the lateral lid crease approach. And this was a tumor after removal, and that's the pre and post-op. And that's the Burr crease, which runs along the lateral canthal tendon. Now, pediatric orbital surgery is another subset which is quite challenging to the orbital surgeon. One needs to remember that the surgical space in children is smaller. Orbital growth is incomplete in children who is less than 10 years of age, and it reaches only adult proportions after 10 years of age. And incomplete ossification of the sphenoid bone in children especially has to be kept in mind, and we're going to see with a clinical example. Disability-associated light years is again very profound and prolonged in a mismanaged child. So one needs to keep all this in mind while operating on children, especially with orbital pathology. Now, this was a very young patient with pediatric orbital SOL, a 75 days old female infant, just a 2.5 months old baby. It was the observant mother who noticed the prominence of the right eye, as you can see in this, after careful examination. And the baby had right eye proptosis, she had a right RAPD, and she had right EOM limitation and resistance to retropulsion. So we did an immediate imaging and found a large, well-defined space-occupying lesion in the right orbit that was apparently very rapidly growing because the mom didn't notice anything wrong at the time of birth. So we suspected, differential diagnosis we thought of in this age group was probably a malignant over a benign tumor, because the younger the child, more in the chances of a malignant tumor. And the commonest is rhabdomyosarcoma, and the next common is an infantile fibrosarcoma. And because the lesion was well defined, we did a lateral orbitotomy and removed it in toto, and that's the resected specimen. And that's the child in a post-op period. And the HPE confirmed it to be an infantile fibrosarcoma, and then we subsequently referred the baby to medical oncology for systemic evaluation and chemotherapy. A pediatric orbital SOL, another example, a 6-year-old girl child, left eye progressive dystopia. She was a regular beef and pork eater, and imaging revealed an inferior orbital space occupying lesion, and that's the resected specimen. And you can see that she's hardly had any scarring because it was done transconjunctivally, and that's the post-op picture of the girl child. And cystic orbital flow lesions can also be present right from birth, like this boy who chose to get operated only at the age of 6 because of parental concerns. And again, it was approached transconjunctivally and turned out to be an inclusion cyst, and that's the pre and post-op picture. Lastly, orbital involvement in systemic malignancy also has to be kept in mind, like this 6-year-old boy who was male, seropositive with the right proptosis, an RAPD and ophthalmoplegia of 6 weeks duration, which means it was very rapidly progressive, and he was seropositive, and this lesion on his nose turned out to be a Kaposi's sarcoma, and he was having metachronous tumors. He was having two things going on at the same time, and he had a very large infiltrating sinoorbital mass in a CT scan, and only a biopsy, a debulking biopsy was done, and it was found to be a highly aggressive, small, non-cleaved B-cell lymphoma, and his immunohistochemistry was done again to confirm the diagnosis, and he was again referred to medical oncology for further management. And presentation of Burkitt's lymphoma, which is a type of B-cell non-Hodgkin's lymphoma, primarily presenting in the orbit, is relatively rare. It usually affects the lower jaw bones and affects the lower craniofacial skeleton more commonly. So orbital surgery, to sum up, the transorbital approaches are quicker and offer more direct access to the orbital surgical space, aesthetically and functionally superior, and they can be, ideally, orbital surgery has to be compared to surgery in a miniature cranial cavity, because essentially the orbit and its structures are foregrowths of the, just a foregrowth of the brain, and we have equivalent neurosurgical and orbital surgery equivalents, and the principles overlap. So it's just like operating in a tiny cranial cavity. And safe orbital surgery, one should always remember that intraoperative SOL fragmentation should be meticulously avoided unless in a planned incisional biopsy. Otherwise, as much as possible, we have to get the whole thing out with preservation of essential neurovascular structures, intraoperative monitoring of pupillary function, and central retinal artery perfusion. We might have heard neurosurgeons talking of intraoperative neuro monitoring. So the same equivalent that we orbital surgeons do is we always monitor the pupillary function and central retinal artery perfusion, and when in doubt, we'll stop and we'll re-examine and then proceed. Avoid a surgically induced compartment syndrome, and meticulous post-op care has very rewarding results. And thank you for your patient hearing. I hope I've stuck to my time limit. Had to rush through, sorry.
Dr. Sitapati, it was really a very interesting talk with so many case records that you had, really mind-boggling. Thank you again. Can I request Dr. Pranita to come over for her talk on phakic IOL from decision?
Good evening, everyone. So I'll just keep the presentation short. I'll be presenting on the topic phakic IOLs from decision making to surgery. So as you all know that the phakic IOLs have transited from angle supported IOLs and iris fixated IOL to the currently used version, which is the posterior chamber IOL. Phakic IOLs is done only in cases for those who are not suitable for cornea based laser refractive correction, and it can be used for correction of myopia, hyperopia, astigmatism, and now it is even done in cases of stable keratoconus. Among all the available options of phakic IOLs in market, ICL is the US FDA approved one and is the most commonly used phakic IOL by most of the practitioners. Even the ICL family has transited from 1997 when it was first introduced to 2016, wherein the EVO Plus IOLs came, where they had a central center flow that improves the safety of these lenses and also increase the size of the optic so that decreased symptoms of glare and halos could occur to the patient. The other lens which is commonly used by the practitioners is IPCL because that is more cost effective, produced by the Indian company, and also gives an advantage of correcting higher refractive errors up to -30, while ICLs can correct only up to 18 diopters. It is important to look at the design of these two lenses for correct surgery to be done because they have different hole orientations. The ICL as a whole and the leading right haptic and on the left trailing haptic, while the IPCL has a notch on the left side and two holes in the optic which should light on the upper lid aspect oriented towards the upper lid. These landmarks are important to remember because they decide the correct orientation of the phakic IOL inside the patient's eye, which is crucial for an adequate optimal vault. Now the clinical examination for any case whose planned for phakic IOL is similar to that done for a refractive surgery. You need to do a proper visual acuity assessment, uncorrected as well as corrected. Then you need to do a refraction, both manifest and cycloplegic, and then check for the POG and look for any change in the refraction. Stable refraction being defined as change in less than 0.5 diopters. You need to assess the patient intraocular pressures and near point of convergence. External eye examination and slit lamp examination is a must in all cases, and special emphasis should be given to a dilated anterior segment examination of the lens, wherein you need to look for early changes of cataract and also subluxation, which is important as it can be seen in high myopes. Next is important to rule out glaucoma, for which you need to look at the disc, do a gonioscopy, look at the anterior chamber depth, and also do a proper fundus screening. The contraindication for ICL, other than what is routine for refractive surgery, is a shallow anterior chamber depth. Anterior chamber depth less than 3 mm is a contraindication for ICL, and also any zonal abnormality or lens subluxation becomes a contraindication. So in investigation, what you need to do is a corneal topography, which will give you a detailed idea of the keratometry, pupillary diameter, AC depth, white to white, all these parameters which are crucial in deciding the size of the ICL. Other than this, you can do the optical biometry and white to white with a digital or a manual caliper, and a specular microscopy because there are given guidelines for the endothelial cell count below which ICL shouldn't be done. So when do you want to go for phakic IOL? The criteria of residual stromal bed thickness, percent tissue ablation, or percent tissue altered, and post-op expected keratometry are the three things which we need to look at with the patient's refraction and corneal thickness needs to be calculated. And if the RSBT is less than 280 or the PTA is more than 40 or the post-op expected keratometry is becoming too flat or too steep, that is when you want to do a phakic IOL. Now, Unlike post-cataract surgery IOLs, ICL comes in different size and not one size fits all. On the basis of the AC depth and wide to wide, the ICL sizing is done. Hence, assessment of these two parameters is very important. Subjectively, the wide to wide can be assessed with the digital calipers and objectively with the help of OpScan, Pentacam and IOL Master. For AC depth, Pentacam, IOL Master, Lenstar and ASOCT all can be done. Important is that when you assess an anterior chamber depth, it should be measured from your corneal endothelium to the lens capsule, and you should exclude the central corneal thickness from the measurements. Now when you have calculated all these data, you send these data to the company, and the company sends you back this form of a sheet wherein they give you an estimated power of the lens and size, which you need to cross-check. If the patient has a cylinder more than 1 diopters in refraction, you should prefer for a toric ICL, and they also give you a rotation chart on the basis of which you decide the axis of implantation. Now IPCL is a little simpler here because the axis of implantation is always 0, 180, whether it is toric, non-toric, but for ICL slight rotations may be required in toric ICL. Now phakic IOL does not require complex surgical instruments nor complex equipments. Even if you don't have a topography system and you have a patient of high refractive error, you can plan it for your own setup because it does not require sophisticated equipments. So even if you have a manual keratometer and a manual caliper to measure the wide to wide, and you know that the chamber has an adequate depth and gonioscopy shows the angle is open, you can still go ahead for a phakic IOL in your practice. Now this is a surgical video showing how to load an ICL and how to inject it. This is the cartridge which comes with the ICL lens. Initially a BSS is injected into the cartridge, followed by injection of the viscoelastic to provide a nice cushion for the lens. The ICL comes in a solution bottle and with a sponge. With the help of the sponge, this lens is removed out of the vial and then carefully placed on the back end of this cartridge. With the help of the sponge, it is engaged into the cartridge. Both the edges are engaged, and with the help of a crocodile forceps or an acephale forceps can be used, with which the lens, ICL lens, is then pulled inside this cartridge. Now this lens is left 2 to 3 millimeters behind the tip of this cartridge. Now this is loaded onto the injector system, on the back of which is a sponge which pushes the lens forward. Now 2 side port entries are made in the patient's eye, and following which viscoelastic is injected. Do not overfill the chamber, it should just be an adequate fill. A 2.8 millimeter incision is adequate to inject this ICL, but yes, if you are beginning in the early phase, even a 3.2 millimeter incision can be made. A very careful entry and a slow entry should be made to avoid damage to the lens capsule. The cartridge should be completely engaged into the wound, or you can even do an anterior chamber assisted incision. You should gradually push and retract the backside of this injector system so that there is no sudden injection, and gradually allow the ICL to open. Once you're sure that the leading haptic has a hole on the right side, then inject the entire lens, giving time for both the edges to open up clearly. You can use a blunt spatula to then tuck the ICL haptics beneath the iris, and just be very careful to avoid any undue pressure when you're doing this to avoid any zonular damage, and also don't touch the center of the optic. Always try and stay at the edges or the haptic side. After this, a bimanual coaxial irrigation aspiration can be done to complete the procedure. Now, the surgery, as simple as it is looking, may not always be that rosy and gold. Sometimes an inadvertent fast injection of the lens in the ICL may turn out to be inverted. You can see the ICL here is being injected, and before both the edges open up, the cartridge is retracted and lens is injected in a hurry. And at this time, the lens flips and you get an inverted ICL. If you give time to it, and just when you see that one edge is not folding properly or is still lagging behind, you can turn and twist the cartridge in the opposite direction to avoid an inverted opening of the ICL. Once an inverted ICL has been injected, it needs to be explanted and re-injected. Don't try and flip it inside the chamber, as it leads to a lot of endothelial cell damage, and you can even damage the lens capsule. So this is a surgical video where we can see the explant of the ICL. This is a patient who was planned for ICL explant and cataract surgery. So what is important is, again, you just need a 2.8 or 3.2 millimeter incision. You don't need a very large incision. First, the haptic needs to be disengaged. Only one haptic is disengaged and engaged into the wound through which you want to explant. With the bimanual technique, with 2 forceps, you just pull it out. The lens is very soft and malleable. You don't need to increase the incision. It will just come out through your 2.8 millimeter incision. Now, this is a patient who had post-IPCL insertion developed an intumescent cataract. You can see on the IOCT there was minimal gap between the IPCL and the lens capsule. So here a viscoelastic was injected both beneath and above the IPCL, and the IPCL is now being turned, and so that it is horizontally oriented with the haptic being in direction of the wound, and through the 2.8 millimeter incision, again the disengaged haptic is pulled with the help of one McPherson and with the help of other McPherson. Again, now it is being just rolled out of the eye. Now, post-operative assessment in cases of ICL, you need to look at the patient's vault. That is the most important thing on day 1 when you see the patient. On slit lamp examination, subjectively, you can look at the vault while comparing the corneal thickness to the vault. Vault is the gap between the posterior surface of the ICL and the anterior lens capsule. The ideal vault is 500, and anywhere between 250 to 750 is fine. So you can just compare with the patient's corneal thickness, and if it is equal to 1 corneal thickness, then you are in the safe zone. The objective method of assessing the same is with an ASOCT, which will give you a more precise idea of what the vault is like. So coming to complications intraoperatively, as we already saw, inverted opening of the ICL is one of the major things that you need to look at. And sometimes while loading the lens, the ICL edge may chip off if you don't have a proper hold or if your forceps is too sharp. Also, damage to the lens capsule is something that can happen if you are not making a cautious entry. Post-operative, in toric ICLs, rotation of ICL can happen sometimes. That is mostly if your sizing of the ICL is not right. So whenever you have a rotation of toric ICL, first thing is to go back and look at the white to white and AC depth calculation and the data that you have sent to the company. Other than that, cataract, glaucoma, uveitis and pigment dispersion are the other complication, although they are seen very rarely. So phakic IOLs, to conclude, can give you good refractive outcomes. A good pre-op planning is essential. AC depth and white to white are the 2 most important parameters that need to be assessed cautiously. Surgery is simple and does not have a very long learning curve. Thank you.
I call upon Dr. Nagendra Prasad sir for his talk on posterior polar cataract, my way.
Thanks. At the outset, I'd like to thank POSCON for giving me this opportunity to speak in front of you. My topic is phagoemulsification in posterior polar cataract. My way, there are various ways to do the same thing by various persons. So I have a little of a modification, but I am sticking to the basic of the procedure. I do not have any financial disclosure. Why it is important to discuss separately? Because of the likelihood of having a posterior capsular defect or adherence of the opacity to the posterior capsule and having high rate of intraoperative posterior capsular defect. So this is a type of cataract we see in posterior polar discoid shape. This is a cataract and the opacity going behind the posterior anterior vitreous, so there may be likelihood of having a pre-existing defect. Again, the defect, these are the combined with the sclerosis of the nucleus. These are very difficult to deal with. So I am not going to the detail of the grading of the nucleus and of the posterior polar cataract right way. But often there is a dilemma whether there is a pre-existing defect present or not. This is a slide I have borrowed from Dr. Pranav sir. He has a good idea to do opacity in those cases when we see there is a opacity here and it is not adherent to the posterior, so it will be a little safer. But nevertheless, you should not be complacent because these are the posterior capsules which are very thin in nature. This is the same another picture. Here again there is a posterior capsule and not adherent to the opacity, and here you can see the adherence. So you have to be little more careful while doing the posterior polar cataract surgery in these cases. So far as consideration is in surgical techniques is concerned, anesthesia, we have to look all the possibility of the steps. Like anesthesia, it should be, if you are not well versed with the topical, so don't go for the topical, always do under peripheral block. wound construction is a similar, it is like that it should be more of the corneal side if you are doing, because if you want to convert in the midway, so you can easily convert in to the other modality of the nucleus removal. Phaco-parameter is definitely a very important steps, and you have to have reduced your parameter by almost 25-30%, whatever you are doing. Capsular axis, though it is recommended that you have to have a small capsular axis, because in a event of adverse effect like VC rupture, you can implant diolundum, but at the same time, I advocate to making a axis slightly larger, not very large, but slightly larger, because of the fluid trapping into the capsular bag might rip the posterior capsule. So it is better to have slightly larger capsular axis than the routine procedure. Hydro procedure is not recommended in this case. Hydrodissection, only hydrodelineation is recommended, and I have my way to hydrodelineate the things. Nucleotomy should be in a such a way that you should not make multiple pieces of the nucleus, and because if you have a nucleus, large pieces nucleus you are consuming, because it is a soft cataract, so it comes easily in this phacotype. So don't make multiple pieces. In the case of adverse effect or defect, it might the free nucleus piece might fall into the vitreous. So have to have larger piece of nucleus to consume. I'm going to have a short video. This is a case of posterior polar cataract, which I have done. Making a rhexis, I have been using the cholesterol guide for this. So almost 5.75 or 5.5 millimeter of capsular rhexis I used to make in these cases. Like this, you can beautifully see over here. Now hydrodissection, I have hydrodelineated this in this case, and I am consuming and just aspirating the nucleus, because it is a very soft nucleus. So I use a chopper to mechanically separate the endonucleus from the rest of the cortex, and with repeated maneuver I am able to consume it like this. So we are not going to disturb the posterior capsule, and once you consume the nucleus, you can easily irrigate, aspirate the rest of the cortical material and implant the lens. Again, this is another case. Here I am going to see how I do hydrodissection, hydrodelineation. So I inject a small fluid. Like you just see that I am injecting the amount of fluid which is not going behind the posterior opacity. So multiple quadrant injection of small fluids might loosen the nucleus from the rest of the capsular bag, so making your surgery easy. So this is the way I do most of the time in this posterior polar cataract. One comes to it, don't rotate, though I have just slightly rotated it, and I am holding the nucleus with the only aspiration power and chopping it. I am not using any phaco power in this case. So like this, I am doing nucleotomy. I am aspirating the nucleus, and I am not making it multiple pieces, because though it is a posterior capsule is intact here, but in case of rent and all, the nucleus piece will go inside. So the cataract is all the time sticking to the phacotype. That way you can safely remove it like this. There is chances of having, in case of event, going to the vitreous cavity. So that way you can do. Again, here I am. Okay, so again here. This is a case of, again, posterior, very typical case. I successfully completed, but you see, just I attempted to remove that plaque, and look what happens. It just touched and it get ripped open. So don't try to remove the opacity on the table. And just try to remove it and the posterior capsule after. But though I have successfully implanted, this is a toric coil, so I have successfully implanted in the desired axis. So that's all to my weight of doing the posterior capsular, polar cataract surgery. Thanks. I invite you, if anybody going from the audience to the Kochi, so I invite you to my instruction course, Unexplained to Explain, Decoding Visual Loss, on 12th of May, 14:30 to 15:55. So most welcome to encourage us. Thank you.
Thank you, sir, for sharing your valuable experience with us. And never have people been so eager.
Here, and I'll just take a few minutes before the next session starts. I serve as Professor of Ophthalmology in Cornea Cataract Refractive Services in All India Institute of Medical Sciences, New Delhi. And I am contesting for the post of Indian Journal of Ophthalmology here. Have contributed significantly to the promotion of academics in Indian ophthalmology and for students with enough experience for taking on the job requisites for IJO here. I do think that many of us do remain disinterested when it comes to AIOS elections, so please consider this as a personal request to all of each and every one of you, and I humbly seek your support for my candidature and look forward to your voting, which starts at 5 p.m. from tomorrow till the 8th of May. Thank you so much, and thank you for the opportunity to talk to you all. Thank you very much.
A very academic person, and we know how suited she is for this post. Thank you, moderators and chairpersons.
So for every team we have 15 minutes allotted, and we have these snipers in the form of Dr. Vibhuti Prasanna sir and Dr. Nilesh Mohan sir. They will target both the judges and the team members. So be aware of them. Beware.
Dr. Sudhir Kumar, Dr. Subhash Prasad, and Dr. Nagendra Prasad.
Sequence means which team will come after which. So Ashiana ki Asik is first. Who is second? Dr. Ajit Dwivedi. So you are second. So your sequence is second. You have to remember this.
Patliputra bombers are fourth.
And Ashiana ke Ashik are red colored because we believe in bloodless surgery. We want to say we are bloody, but we go for bloodless surgery.
Just to have a little bit clarity of the whole show, how we are going to conduct it, we have 4 teams, we have named them, we have color coded them. In one go, they will start with their promo video and they will continue with their scientific presentation, video presentation. At the end, they will be judged by our esteemed judges. They can ask questions to their satisfactions and they will give the marks. Each team has 3 members. Each video is of 4 minutes. Each team will have 3 videos. So at the end, the whole marks will be given. Now, we may ask their average.
Save this. This was the promo. इसलिए बच के.
Good afternoon. I am Dr. Vishal, the vigilant surgeon.
Bows before your grandeur. No other being has ever had the might, nay the nobility, to wield not one but 2.
So after making my proper wound and doing capsule rexus, I noticed that since this was a mid-dilated pupil, my rexus were small. So I planned to enlarge. I used a Vanus to first give a neck and then used a epsilon capsule rexus forceps to enlarge my rexus to the desired size. And to this I was successful, and this is important to avoid any further complications in my next step. Then I started my phaco and I planned this slight trenching so that I could get space for direct chop. And with this plan I started, but as I was trying to hold, initially I was not getting the grip because the small pupil size. So again I retried and oops, I noticed something, so I stopped and there was ZT. So I stopped to plan my
Mighty Thanos, I, Loki, Prince of Asgard, the rightful king of Jotunheim, God of mischief, do hereby pledge to you my undying fidelity.
Undying. You should choose your words more carefully.
After noticing ZT, I plan to use RS hook to secure this jetty properly. And with the size of the jetty, I decided to use 2 RS hooks. And first I made a neck with the ambia and then inserted 1 RS hook. And slowly I first put it in the capsule, capsule margin, and secured the one side of the jetty. And then I inserted the second RS hook. I secured the jetty from the second side. And after this, I injected viscose to properly inflate my chamber and finished the phaco in a slow parameter, like I diffused the bottle high, and I made a point whenever I just withdraw any cement from the antechamber, I have to inject viscose so to avoid fluctuation and safely so I complete my surgery. Then this last needless piece was left, which I moved in 80 needless mode. Once this was over, I just did irrigation and aspiration by manually and then injected foldable iron and dialed it into the bag and checked for the centration, and after doing it properly centered and use the spatula to that any vessels was there in the injection or not. Then I removed my ISO and completed an specific using some loose contact in the chamber and visco and finished off.
दारू शारू दुल्हड़ दो विस्की का पैक लगा के सारी दुनिया बुल्लड़ दो Party all night, party all night, party all night, we do party all night.
So, our next team member, Dr. Rakhi presentation.
Deep anterior lamellar keratoplasty, commonly known as DALK, is a procedure of choice for corneal opacities sparing the endothelium. One step which makes it different from PK is dissection of a stroma and sparing the Descemet membrane. Though it provides many advantages over PK, at the same time it throws challenges by showing its different mood. Among all adverse events in DALK, DM perforation remains the commonest, which may even require conversion to PK. In this video, I am going to show you few challenges that were encountered and overcome. Here I go with my first case, a 28-year-old lady with advanced keratoconus and with hard cataract with posterior polar component. Other eye had field eye drop, so overall vision was 3/60. So I gathered all my courage to perform DALK and phaco. Till IOL implantation all went well. While dissecting a stoma with groove and field technique, I noticed one small DM perforation. Okay, fine. I kept on doing. Oh no, one more perforation and that was little bigger and AC started shallowing. But I had no other choice and secured the top without losing AC. Next day, there was DM detachment. So C3 injection was given, and after 1 week, patient came with BCVA 624 and then 612 at 1 month. In this case, identification and proper management of perforation led to excellent visual outcome. My next case was a 17-year-old young boy underwent DALK right eye for advanced keratoconus. The surgery was uneventful and I was really very eager to see the post-op results. Next morning was not at all good for me. There were multiple infiltrates present in interface. On very same day, I decided to replace graft and send all the samples from donor and host for micro workup. Post-op day 1, graft and AC were looking okay. Smear showed gram-negative bacilli and culture grew Klebsiella pneumoniae. So we started topical therapy along with oral steroid. On post-op day 2, there was recurrence. By that time, we received sensitivity report showing Klebsiella was multi-drug resistant and only sensitive to collagen. So we started 0.19% collagen drops. Stimulating after 3 days, we got pair of good optical tissue. So performed third peaking in C mile and continued collagen for next 1 month. Following which patient achieved 6x vision with minus 1.5 diopter cylinders, and here that completes our journey of tackling interface keratitis for the very first time. Thank you.
An uneventful smile refractive surgery for myopic correction. And here you can see the docking going on for the left eye here. And I'm sorry, I didn't have a voice overlay for this one. So I'm going to speak and explain to you. So here you're seeing the dock happening, all uneventful and going on completely. You can see the laser firing here, the lenticule being made, the cap cut also done here. And the patient is now moved on to look at and remove the lenticule dissection. This is one of the rare complications which you would see of smile surgery, and this does happen infrequently in people who are learning their surgeries during their learning curve here. So as we go in to dissect, as you would see, the first dissection is onto the left aspect of the wound entry here. And you would dissect the anterior plane of the patient here. So you can see the anterior dissection happening in this particular option. The right half is the dissection of the posterior plane of the lenticule here. So this helps to identify and keep the dissection plane separately, and you need to enter in the right plane to define and continue with the surgical dissections here. So as you can see, the meniscus sign was well delineated in this particular patient, and the anterior cap is being delineated and separated from the lenticule in this here. So I'll just run through a fast phase of this, and all seems okay. And now the dilatation, when I'm going to dissect the posterior, I realize that the posterior part is not separating at all. So this is an important identification here to see that once you're not able to make out the posterior plane dissection, an early suspicion that the lenticule is now adherent to the cap. So a cap lenticule adhesion is common in up to 9% of cases when there is a misdissection of the anterior and posterior planes of the refractive lenticule here. So you can now see that I'm able to go and delineate the cap, the lenticule, which is stuck with the cap of the cut of the smile surgery here. So identification and slow and gentle separation of this lenticule from the adhered cap is important to complete this surgery uneventfully. Otherwise, dissecting down into the posterior plane, thinking that the lenticule is behind, will result in scarring of the entire stroma and will cause grave opacifications of this otherwise uneventful surgery with a potential 6.665 vision in this eye here. So the separation of the adhered lenticule to the cap is known as the lenticulorhexis surgery. So many of you here would not have seen a lenticulorhexis here. So this is a lenticulorhexis which is happening. You go around 360 degrees and separate the lenticule which has been adhered to the cap of the smile laser abrasion here. And once you're able to separate it out, you could go in with a microforceps and peel the entire lenticule out, and that will help you to successfully complete the surgery, and also taking care that none of the parts of the lenticule are left behind adhered, because that again will lead to postoperative induced astigmatism and decrease in visual acuity, postoperative refractive outcome as well. This is a particular difficulty, and if it is not recognized, especially in the beginning phase of doing your smile surgery, then it becomes a difficult to smile situation, and the surgeon forever always would stick on with just doing a femto-LASIK here. So this is one of my cases which I did about 2 months ago here, and here it all went well after dissection, a small tear at the flap here, and thankfully the surgery went well, and put in a BCL after the surgery, and this patient was 6'5" in the immediate post-op here. So I'll stop here for the opportunity to present this rare surgery of lenticulorhexis in a case of capsule adhesion to the lenticule adhesion to the capsule. Thank you.
Thank you, ma'am. So, our team well in time, and ma'am, in spite of without any coordination.
So well, Ashiyanage Ashik have finished their entire show.
Little more to avoid your journal dialysis, and we were surprised that you didn't put any CTR.
That's the thing, sir. In our OT that time we didn't have CTR. This IRA hook was available, so we chose what all the options we had at that time. Otherwise, CTR was, because of this size of ZD, CTR was the best option.
To me, it appears to be a pseudoexfoliation syndrome.
Pseudoexfoliation? No, sir.
It was not there. So, okay.
Okay, so whatever I am seeing, that means judges, are you not happy with this team red?
No, quite happy.
Quite happy?
But not happy with Badmaas, thoda sa.
Yes, that is what I see. There has been lot of messages floating around, and you know, they were so scared of you, sir, that one of their team member left the match. That was me. And they had to outsource one player from Delhi. What's going on? I think the only person who can answer this is Dr. Nilesh Mohan, sir. Sir, what do you say?
IPL का जमाना
What is going on, sir? Sir, remember, for the benefit of the audience, let me tell you that we have installed the Pegasus software and all the chats on WhatsApp is being read.
No, Vishal, they have done a very good job. This judge is biased with this team, so they have done an excellent...
Oh my God, what is going on?
Sir, thank you.
Sir, didn't expect this. Didn't expect this from you. What is going on, sir?
Third umpire is
जज बायस्ड हैं, तभी तो इतना नंबर दे रहे हैं. नहीं तो कहीं और काट नहीं लेता.
So would you suggest that they should revise the marks they are planning?
I would know the marks, then only I can say
no,
whether...
I will, but we have to pressurize them, isn't it?
But I think they should revise it in the positive side.
Otherwise, what punishment you have in your mind, Dr. Vibhuti Prashant Sinha, sir? If they don't do the justice.
To the judges?
Yes. No one will be spared, sir. You are snipers, you know, third umpire.
पटना में रहना है.
अब लीजिए, मतलब इतना डरा उड़ा के चला, मामला गड़बड़ है. Means you got the message. The third umpires are scared.
This is other way around. Judges are being punished instead of those who are doing the surgery. ये कोर्ट की तौहीन है, तो हम लोग quit करते. Anyway, except. Coming to video, so this is our first video. A 5-year-old pediatric traumatic cataract presented with total cataract, and at that time just there was a small dialysis. So first this Saneki was relieved. And iris was stabilized. Rhexis initiated, but due to fibrosis, it was difficult. So at different stages, it was cut. So during surgery, it was found that there is dialysis also. Subluxation also, So CTR was put. At that time, basically signage was not available. So, and then 3-piece IL was implanted. After that, Hoffman pocket was created to repair the ardelysis. 90 fluorine was threaded in 26 gauge needle. Tricot was injected to see any vitreous is there. Surgery completed. Second case, again a pediatric cataract with, pediatric traumatic cataract with opacity. In these cases, we can't wait for triple procedure. So I have taken this patient for surgery after capsular staining. So rhexis was started from the clear area, but at this moment I got stuck. So again from rhexis started from other side. At this stage it was going outside, so again it was retrieved, and then rhexis was completed to check any residual capsule fiber. Again vitrectomy was done. So after that cataract was soft, so it was aspirated. Single piece IL was implanted. Then optical iodectomy was done in the clear area on both sides. This completes our surgery. Thank you.
I am Dr. Roshan Kumar from AIMS Patna. Unfortunately, Satyaprakash Tiwari sir had to leave for some work. So just 5 minutes before the start of this session, my HOD sir has told that he is not here, so you have to present. All surgery are done by Satyaprakash Tiwari sir and not by me. So hope court of law will consider this fact. This is first case of intraocular foreign body with endophthalmitis. Entry wound was closed by 10-0 nylon suture, and foreign body in anterior chamber was removed. This is case 2, glass intraocular foreign body in anterior chamber. This is case 3, intraocular foreign body with intra-endophthalmitis. 23 gauge vitrectomy was done, and vitreous hemorrhage was cleared. And this intraocular foreign body was removed with this is magnet. With the help of magnet, this intraocular foreign body was removed. And entry wound was closed with 10-0 nylon suture. This is fourth case, intraocular foreign body with vitreous hemorrhage. Vitreous hemorrhage was cleared with vitrectomy. And this is intraocular foreign body, which was removed with magnet again. And surrounding area was lasered. And port sides were sutured with 80 Vicryl. This is fifth case of intraocular foreign body with vitreous hemorrhage. This is port site was enlarged with MBR blade and intraocular foreign body was removed with the help of magnet. By enlarging the port site, this is magnet, and with the help of magnet it is removed, and with the help of limbs forceps was removed. This is sixth case of intraocular foreign body with endophthalmitis with vitreous hemorrhage. Vitreous hemorrhage was cleared. All cases were done with 25 case vitrectomy. This is seventh case of subconjunctival pencil tip. Altogether there are 9 cases of intraocular foreign body. This is seventh case. Thank you.
So Dr. SPT has some personal reason, so he just, Dr. Siddhesh, thank you, Dr. Siddhesh, Dr. Rasan, and he has just come up, he has just come, just 5 minutes before he has seen the video and he has done a tremendous job from our side. So glaucoma management requires multiple arrows in your armamentarium to use as and when required. This case series shows many battles won wherever it's required after trabeculectomy and releasable sutures surgery. This young man of young glaucoma post-trab failing bleb needling itself helped to reduce the IOP from 44 to 8 mm of mercury and good bleb later on. Even cataract in glaucoma surgery requires careful site selection and future sparing of area. This CACG patient has failed trap surgery, has undergone redo trap surgery in one area and developed cataract thereafter. He has undergone phaco surgery. Other area has been purposefully left for future intervention. But sometimes, just like ward, you will find a awkward situation where previous trap wound was found sutureless and leaky when AGV was implanted. This patient has presented to us just after first COVID lockdown. As patient was one-eyed, it was decided to complete in one setting and completed successfully with AGV implantation. 23 gauge needle with tube inserter was used to place AGV tube in scleral tunnel to avoid patch graft.
After suturing the wound, AGV was implanted. It was a very large wound leak. It's around 8 millimeter. So I put around 10 to 11 sutures, and then that AGV was implanted in other area. There were 4 to 5 cases on that, 5 cases on that day, but it took around 2.5 hours for the surgery, suddenly.
Glaucoma valve patient requires careful phacosurgery. This uveitic glaucoma was implanted AGV at IOP of 70 mm of mercury and found to be a steroid responder. Later, cataract was managed with careful phaco under low flow settings to avoid any AGV disturbances and maintained with 6/6 vision without medication even after 3 years of surgery. This series signifies the importance of glaucoma management as holistic and individual case-to-case basis, which leads to a good quality of life for a glaucoma patient.
वेल सगुना मोर के शहनशाह, अभी अभी आशियाना के आशिक के साथ बहुत कुछ हुआ है, तो आशिक साहब आप कुछ कहना चाहेंगे शहनशाह के बारे में?
आपका एक प्लेयर भाग क्यों गया?
शहंशाह जो है घर से
कहीं
निकले
जज
थे।
से कुछ?
शहंशाह जब निकलते हैं रास्ते में वीरानियां होती हैं, सारे समाज घूम जाते हैं और कभी कभी उन्हें भी बुलावा आ जाता है, इसलिए वो चले गए।
ऐसा नहीं हमसे डर के भाग गए?
वो यही थे, उन्होंने अपना वीडियो भी भेज दिया, यंत्र यही छोड़ दिया।
कहीं और शिकार
felt that there was gross decentration of the lens even after putting the IOL. Was there any vitreous loss also there? Because you told that there was some jonular dehiscence, but after putting that, you put ring, no? CTR. CTR should have kept the bag in the place actually.
Basically, capsule was very fibrous, so it was not possible to center it at that time. And Sionage was not available, so we can't suture it at that time moment.
And another thing that, are you sure that in the second case you could do a very well centered, or you complete the CC?
It was well centered.
CC, this capsule axis, you could do that.
Yeah. After retrieving from the right side, basically 6 o'clock, vitrector axis was done to rule out any tag. If it is there, it was cut. So vitrector axis.
No, in second case with corneal opacity, were you able to do capsular axis?
Yes. First it was started from 12 o'clock. Then I've gone to, in center I got stuck. So I have started from the other end. And at that moment at 6 o'clock, I have came to the center. And then capsule tag.
Because it was not very much visible from here, that's why I asked.
But it was not viewed, although I just to basically negate any chances of capsular tag, I have done vitrector axis also, vitrector axis to cut any capsular tag if it is there. But again,
so what I feel that if there is any doubt that you have not done a capsular axis, better would have been to put multi-piece lens in the sulcus and.
Basically,
that's my.
3 quadrant, I was confirmed that rexis was intact. So that is why I have implanted IOL.
Another thing is that to increase the visualization, one can use the endo limiter through the, not actually in the vitreous, even with the side, through near the limbus, if you put, you can get some better view.
So here I would ask our third umpire, sir, do you think there is something anti-working here? Too many questions from Saguna Morke Shahanshah, and here Shahanshah's position is at stake. I have a very serious thing about it, sir. What is your information?
नहीं वो तो he is fond of asking questions.
ना जिससे
He's
ज़्यादा
fond of
क्वेश्चन
asking
पूछ रहे हैं वो
questions
तो
and
अच्छी बात
sometimes
है
it is
भाई.
pertinent one also. और ये जरूर बोलेंगे कि हाँ पहली रेड टीम से एक थोड़ा सा एक पेपर था उसमें रेट्रो इल्यूमिनेशन और स्लिट इवैल्यूएशन लैंप इसका illumination का for corneal opacity patient that could have been used, but otherwise हमको लगता है कि जज इसमें बहुत अच्छा काम कर रहे हैं. कम से कम एक जज, बाकी दो जजों का तो नहीं पता.
I think he has not opened his mobile.
Rest two are already bribed. Only one judge is upright. He is asking question.
Amit ji,
the Pegasus spyware, what it says, see the message that has floated on WhatsApp. Adarniya Subhash sir, listen to this message. Adarniya Subhash sir, सादर प्रणाम. दीघा से होकर फुलवारी को जाने वाली फ्लाईओवर का रुख मोड़कर राजा बाजार के फ्लाईओवर में मिला देंगे. कल के वीडियो का ध्यान रखिए.
भाई this is a very serious charge.
Amit,
so
judge तो
sir,
क्वेश्चन पूछ ही
why
रहा
we
था.
needed third umpire? Now you see, sir, please. I cannot tolerate this. Nilesh Mohan sir.
जज क्वेश्चन पूछ रहा था, मरीज भी पूछा कि दिखेगा क्या. इंजीनियरिंग तो बहुत अच्छा हुआ.
All these cases in pediatric cataract, you have to clear the visual axis as early as possible. Although in that case, triple procedure was recommended, but due to, you can say, unavailability of cornea, first you have to clear the axis as early as possible. In that case, cataract was removed. Optical aidectomy was done.
Okay, so now our third team is roaring to go. पूछिए जो दिल में भरा से निकाल लीजिए. Quick question.
उसमें किया गया.
सब चाहिए fair play चाहिए fair play चाहिए fair play चाहिए fair play चाहिए fair play. सब चाहिए fair play 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 चाहिए मुझे सब चाहिए fair play चाहिए fair play चाहिए fair play चाहिए मुझे सब जो भी सपने मैं देखूं जिस पे हाथ भी मैं रख दूं मुझको वो चाहिए fair play fair play. I got ways and I got skill. मुझको कहता है मेरा दिल I'm gonna get it right, yeah. Fair play, fair play, fair play. Change होगा जो भी सीन है जो तू खेलने को कीन है बाजी बड़ी ही हसीन है You know what I mean, right? लगी सपने में देखूं जिस पे हाथ भी मैं रख दूं मुझको वो चाहिए fair play.
सीधा एलिगेशंस है, फेयर प्ले नहीं हो रहा है.
Good afternoon, everyone. I'm going to present a case of a 4-year-old child presented to us with the palate injury, ankyloblephron with thighscale eye. The see here. Patient was taken under general anesthesia after injection of the local anesthetic agent to prevent the bleeding. Incision was given on the upper lid to separate the ankyloblephron. Just to insert the spatula to see their phonics is preserved or not. Then with the help of the spring seizure, we separated the lower phonics. Just to say, ankyloblephron is not only the lids adhere, it is also adhere with the cornea, the globe. So again, separation of the upper lid was done with the sharp dissection was made. The gently dissection was done to preserve the remaining cornea so that further we repair the lid with the conjunctiva so that further adhesion should not happen. After completion of the separation of the upper lid, again we have to see if it is complete separated or not. Then just you see here again conjunctiva adhere with the globe and fornices of the upper lid. We cut it, and after the cutting of the separation of the fornix lid, just you see the eye is icicle. Globe was separated, lid was separated with the speculum, and 360 peritomy was done as we everyone do for the enucleation. We plan the enucleation. As you see here, due to the adhesion of the conjunctiva and tenon capsule with the globe, it is very difficult to separate. But gently we have to separate the tenons and conjunctiva because if you not preserve and separate, then after the implantation of the implant, after the implantation of the implant, there is the risk of exclusion. So gentle dissection is done to separate the conjunctiva and tenon 360 degree. After complete separation, we look out the all the recti muscle, 4 recti muscle was separated and secured and cut it. Just as the inferior rectus muscle, then lateral rectus muscle, then the superior rectus muscle, then finally the medial rectus muscle. It is secured, then enucleation was done. After the enucleation, hemostasis was maintained and PAMA implant was inserted, and all the recti muscle was sutured to each other so that post-operative patient will maintain the ocular movement. Tenons was repaired in the layer, in different layer, particularly the horizontal followed by the vertical, so that it will protect more to prevent the exclusion of the implant. After the completion of the tenon and conjunctiva, suture was used 60 Vicryl absorbable suture. Then lead was debridement of the scar tissue over the lead was done so that it maintained the proper position and margin of the lead. After the completion, then conformer was implanted. On the follow-up, just you see the patient will presented to us, and after the implantation of the prosthesis, result was satisfactory for patient and surgeon. Thank you so much for your patient.
Next presenter is Dr. Tarun.
Some motions are so vast that they are difficult to analyze. Time is in fact an arbitrary human-made concept. While a second always takes place the same amount of time, the human internal clock is a metronome working at high variable velocities. A blink is 100 milliseconds. Pupil constricts in 200 milliseconds. The cover test, one of the most important tests for strabismus, appears simple but is actually complex. Eye shift in cover test takes place in 400 milliseconds. Slow motion to study fast-moving objects was first invented by Dr. August and has been used in sports since long. In medicine, it was introduced in 2013. We used this technique for the cover test. We took video during cover test on Android phone. The video was transferred to UCAT downloaded from Play Store. The video was copied twice and speed of 0.5x and 0.3x applied to the second and third video. This video was then played and replayed on the media player. Here we can see the exoporia becomes more apparent in slow motion. We decided to do a pilot study. A group of trainees were shown the cover test. After that, video recording of the cover test was made, and the recording was then showed to them. They perform better by using this technique. A normal photography in this case shows left exotropia, but the slow motion shows poor fixation in left eye and loss of fixation when the cover is removed. Using this technique, we can assess and teach such fine aspects easily. Here we see small angle left esotropia with loss of fixation after some time. Here there is loss of fixation after a blink. Since we found this technique very useful to us, we decided to share this technique with strabismologists over the world and get their opinion and feedback. They found the technique innovative and suggested we use it for DVD, PSD and microtropia. They also suggested that we could use it for nystagmus and counseling of the squint patients. Slow motion dynamic videography of the cover test can be helpful in the detection and analysis of strabismus. It can also be used as a teaching tool for future generations.
This is the case of a 14-year-old boy who underwent GRT surgery in his center but couldn't achieve the desired result. The patient was referred to me for a re-intervention. We can see here that multiple bubbles of PFCL which are scattered all around on the posterior fold. They were removed by using passive suction. The retina had developed permanent folds and it had folded upon itself as well. There was a fold which was underneath. So it was a double fold, inverted fold sort of thing. We use the diamond dusted scraper here to unroll it. In my hands, the diamond dusted scraper works the best. Unlike the other forceps, which when I use to untie or unroll the edges, it causes inadvertent retinal tears or bleed. We use the diamond dusted scraper in a sweeping manner. Here we use the light pipe also to see relieve some adhesions which were more firmer and were not amenable for diamond dusted scrapers to be relieved. We use the diamond duster scraper in a manner in which we avoid the supraparietal areas like the macula. We can see that there are still a lot of PFCL bubbles which are still present. We are alternately using the diamond duster scraper. What we can notice here that the surgeon had attempted to make a posterior retinotomy and laser around it, and this had aggravated the subretinal fibrotic process. You use the ILM forceps to remove the chorioretinal fibrosis which is bridging the retina. And once we have removed it and we are up to the satisfaction, we use the vitrectomy cutter to further remove these debris. We see that there are multiple PFCL bubbles which are still present underneath the retina, and we use the passive section of the fluid cannula to remove it as much as possible. Once we have satisfactorily unrolled the retina, we use the PFCL to further unroll it and use it for our satisfaction. We use the brilliant blue dye from Orolab to stain underneath the PFCL to do a arcade to arcade ILM peeling. What we can notice that is there is a tuft of PFCL bubble which is still present. We continue with doing the ILM peeling underneath the PFCL, which is a preferred technique in my hand. And once we have done a satisfactory ILM peeling, we can still notice that there is a fold of retina which is still present at the macula. So once we can see, and what we do is we again use the diamond duster scraper to further unroll and iron out the retina underneath the macula so that this fold can be relieved as much as possible, and this is transmitted to the periphery. Once we have done it, we proceed to remove the subretinal PFCL, the large bubble underneath it. Initially, we try to do it by using a passive section, but thanks to our effort that it came out into the vitreous cavity. The next step is to just complete the 360-degree retinectomy, and once we have done it, we proceed with trimming of the remnant retina, and the rest of the steps are usual in a case of a 360 retinectomy with a 3 to 5 rows of laser and using the posterior retinotomy along with the increasing in the retina. We do a direct PFCL exchange under the Sandlian illumination, and these are 1 month post-op results.
Quick comment from judges.
बात मैं आपको समझा रही थी ना भाई साहब, आज वो मोहल्ले वाले कहकर गए हैं नहीं होगी आपकी किसी भी बेटी की शादी, घर में बैठी रह जाएंगी सबके सब जब तक कि ये लड़की इस घर में है। बस
This is a case of a monoelevation defect, also called double levator palsy, which presents with a 25 prism hypotropia. In this, a NAP procedure is performed. Superior rectus is isolated and freed of all the tenons. Marking is done for the transposition of lateral and medial rectus. Now the lateral rectus is disinserted after tying it with a 6-0 vicryl. Now transposition of the lateral rectus lateral to the superior rectus is being done. Careful scleral bite should be taken. So the most common complication is perforation of the globe, so care should be taken. in taking the bite. Now the medial rectus is isolated and cleared off of all the tenons. Once it is isolated, it is secured with 6-0 vicryl. After that it is disinserted, and after disinserting it is translocated to the superior rectus, maintaining the circle of helix so that the vector force acts superiorly and eye moves from the hypotropia to the orthophoria in the primary case. So now bite has been taken. As you all know, the NAP procedure is the most common procedure performed for correcting a double levator palsy. And double levator palsy with FDT negative, in which the superior rectus is not taut. The best procedure is NAP procedure. You can see how well correction is done. Now this is another case of Duhan's retraction syndrome with a upshoot. The Duhan syndrome, as you all know, is associated with upshoot and downshoot, and to correct upshoot and downshoot, we have to do a lateral rectus splitting. Once you do a splitting, the tautness of the lateral rectus and the sling phenomena which occurs, which throws the eyeball in up or down direction, is released. So now the lateral rectus is hooked and cut and secured with 6-0 vicryl. Now the splitting of the lateral rectus is done so that it becomes a Y. The splitting is done around 10 mm down the line of lateral rectus, and the two arm is secured 6 to 8 mm apart. Maximum spread of the two arms will cause more effect in upshoot and downshoot control. So the maximum separation should be done, and this Y splitting will correct the upshoot and downshoot, which is so very common in Duhan's retraction syndrome. Now measurement is done to see whether the splitting has been done correctly. The two arms is separated 10 mm, and the lateral splitting is also done 10 mm. This is the pre-op and post-op. You can see very well how well we control it.
बात मैं आपको समझा रही थी ना भाई साहब, आज वो
यह फिल्म सत्य घटनाओं पर आधारित है। इसमें आए पात्रों और स्थलों के नाम वास्तविक है। फिल्म में दर्शित किए गए नामों में अगर आपका नाम आए तो खुशी से अपने स्थान पर ना उछले, औरों को फिल्म देखने में दिक्कत हो सकती है।
हिंदुस्तान अब चुप नहीं बैठेगा। ये नया हिंदुस्तान है, ये अंदर में घुसेगा भी और मारेगा भी।
And here the terrorist is fungus, which is invaginated in the cornea for last 2 months. Even cross-border fire of antimicrobials failed to control them, and it is spreading its tentacles in cornea and anterior chamber. Hence, the commander decided to launch the surgical strike to clean up their habitat. A side port was made, and hypopion and endoexudate was washed out as much as possible. Intracameral injection of 0.01 ml voriconazole was given. Now intrastromal injection of voriconazole was given at the junction of infiltrated and clear cornea at multiple sites. Intensive cross-border fire of antimicrobials were continued. After 3 days, intrastromal infiltration started resolving, but intracameral invaders again started spreading their tentacle. Hence, second surgical strike was planned by the couple.
was done and voriconazole was injected in the anterior chamber. Intrastromal voriconazole was also injected in similar fashion. Intensive cross-border fire-off topical antifungals were continued. On a regular follow-up, a stromal infiltration completely resolved after 4 weeks of second injection. There was no recurrence in further follow-up. Another similar cases responded very well, but sometimes scenario and conditions are so difficult that selective surgical strike is not possible because invaders are spread over larger area, but they are so resistant and notorious that they have.
जो सब करते हैं यारो वो क्यों हम तुम करें, यूं ही कसरत करते करते काहे को हम मरे, घर वालों से टीचर से भला हम क्यों डरे, यहाँ के हम सिकंदर चाहे तो रख ले सबको अपनी जेब के अंदर, अरे हमसे बच के रहना मेरी जान, नहीं समझे हैं वो हमें तो है हमारी बाजी को जीतना हमें आता है। गलियां अपनी ये रास्ते अपने, कौन आएगा अपने आगे, राहों में हमसे टकराएगा जो हट जाएगा वो घबरा के, यहाँ के हम सिकंदर चाहे तो रख ले सबको अपनी जेब के अंदर, अरे हमसे पंगा मत लेना मेरी जान।
Well, this was the last.
बधाई, इतना अच्छा प्रेजेंटेशन, सबको हार्दिक बधाई। सब लोग को ताली बजाना होगा, भले 5 बज रहा होगा। हाँ हाँ, लेकिन हमारे यहाँ परंपरा है पीछे से गिनने का, तो हम रनर पहले का बताएंगे।
माइक ऑन नहीं है।
रनर टीम जो है जरूर आशिक ही होगा, क्योंकि किसी न किसी के पीछे भागता होगा वो।
क्या है? आशियाना, आशियाना इज रनर। आशियाना क्या है पूरा? आशियाना के आशिक।
अरे they are not being identified. One should have a photograph.
And the winner is RR. RR क्या हुआ भाई? राजा बाजार।
They were the teams who had challenged before their presentation.
And the best entertaining video goes to Abhishek Anand individually.
Good.
And best scientific content is Dr. Kunal Kishore.
अरे वाह, वाह जी, हमको लगा तरन्नुम कहीं ना।
And best video overall is Tarannum. That's all the results available.
I thought that the judges will be very biased, but I am finding the results to be very, accurate and in accordance with the audience's view too.
आइए सर।
गनर आप, अरे हमको भी फोटो आने दो।
गनर को नहीं मिलेगा, गनर को मिलेगा। हम लोग को स्नाइपर कर करके बोला गया कि
हम लोगों ने काफी जज को चैलेंज किया था इस टीम के लिए, नहीं?
विनर क्या है?
इस टीम के लिए।
गुप्ता सर आज विनर के लिए पकड़ो अभिषेक।
The winning team.
अब नहीं देगा।
And now the third prize.
नहीं है, बेस्ट एंटरटेनिंग वीडियो का
अभिषेक आनंद।
अभिषेक आनंद। सबके बहुत भारी है, सबके पता लगा।
कल पिज्जा आ रहा है, अभिषेक।
सर्जन सीज पेडियाट्रिक ऑफ्थल्मोलॉजी। पेडियाट्रिक ऑफ्थल्मोलॉजी है। अच्छा अच्छा अच्छा।